Hey everybody, welcome back to The Pathway. I'm here with my colleague Sarang Patel.
Hey guys.
And so we're very lucky again to be joined today by Dr. Paul Fu. Dr. Fu joins us from Bronson Health Systems. Today we're going to be talking about some of the challenges that we're facing in the healthcare industry and some of the adjustments and changes we need to make to be able to stay at the forefront of care. There are a lot of unique challenges and a lot of changes that are happening in real time. And whether it be administration related or just where the healthcare industry is going, we know that obviously budgetary constraints, financial issues, there's a number of things that drive how healthcare operates. But right now, we're in a unique time where there are changes coming, changes happening, and us collectively, whether it be a private health system or a private company, we have to adjust and we have to make changes to our model to try to account for some of the changes that are coming. So guys, lead us in. Tell us what you're hearing, what you're seeing, and how we're supposed to adapt to some of these changes that are coming.
Both companies obviously serve all insurance groups. I think that's a big piece of it. Obviously, predominantly talking about Michigan here right now, right? So let's say Medicaid cuts or Medicaid changes that are happening financially, right? So, and correct me if I'm wrong, because I think I would learn a lot from you on this, is although Medicaid covers a lot of the services, right, as far as financial standpoint of it, a lot of that is still subsidized in the back end through federal government budgetary spending, right? So the federal government funds the state level to help pay for a lot of the Medicaid services. So if that changes, right, whatever party, doesn't matter, but if that changes, the structure changes of the payment system in the back end, what does a trickle-down effect look like for companies like us? More importantly, what does it look like for the patients that have Medicaid insurance that are dependent on this for their livelihood, whether it be for headaches you talked about before, or mental health, or whatever it may be. So have you guys at Bronson Health System, I guess, what's the discussion? What's the conversation? Is there fear, or have you heard of fear in other healthcare systems as well of some of these cuts happening? How does a hospital prepare for this?
Yeah, I would say so. I think with the cuts, kind of just from baseline, if you were to look at Medicaid today, the Medicaid services are not compensating hospitals for the full cost of care. And so there is a gap there already. So let's say Medicaid pays for 80 cents on a dollar. There's 20 cents there that's not covered. And so kind of in the traditional healthcare system, the rates are better from commercial payers. And so that covers some of the gap. And so if you kind of have a demographic that's spread out where you have some Medicaid, some Medicare, and some commercial payers, the average hopefully is covering the cost of care. As more patients that are previously on Medicaid become uninsured, we suspect that a lot of the hospitals are going to take on a brunt of those costs. So, I think there's an expectation that patients are still going to show up to the emergency room when they need care if they have insurance or they don't have insurance. And so if they don't have insurance, they don't have Medicaid, they're coming to the hospital. The hospitals are still bound by EMTALA rules to take care of the patient and make sure the patient's stabilized and to provide care. Those costs then go unpaid. So the hospitals are then going to be incurring greater and greater costs as the number of patients that are insured become less and less.
Can you explain, and maybe I know a little bit about it, but the EMTALA rule in general? Because I don't think a lot of viewers know it, or myself in detail about it. My biggest fear is, or question would be, does that even go away? Could that ever go away, the EMTALA rule?
Yeah, I don't think so. I think a lot of hospitals and a lot of healthcare systems are built upon that. And so the EMTALA rules basically means that if a patient shows up to your department, and there's some actually specific rules of, the distance, if they're within the parking lot, does that count? But if they're showing up to your hospital, then it's your duty, regardless of ability to pay, to take care of that patient. And so the patient could have Blue Cross Blue Shield, the patient could have Medicaid, the patient could be uninsured, but it's your job as a hospital to make sure that patient is stabilized. Sometimes for community hospitals, they don't have the full gamut of services. And in those cases, EMTALA rules require that those community hospitals stabilize a patient before the patient can then be transferred to higher level of care.
Got you. Any specialty, any subtype, or is it just only emergency care? Like, could it be like, hey, I don't know when it could be an emergency, but sinusitis. Could it be something as basic as common cold and they want to seek services and they come there? Or is it just only if it's an emergency issue does EMTALA rule apply?
Yeah, so it applies for any patients essentially that shows up in
Gotcha.
the ED. So your job is to see the patient, triage them, make sure that they're okay. Let's say it's something as simple as sinusitis, then you could potentially start them in an antibiotic and discharge them. But the goal is to see them and make sure that they're stable.
Treated.
Yeah.
Interesting. Okay. And this has been in place for as long as we know.
Mm-hmm.
Okay. And so in the acute setting, the hospital system, like you said, will take on the brunt of cost and then left with it. So how does a hospital system overcome excess burden in other areas?
Yeah, it's tricky. So, coming from Massachusetts, there's definitely systems in that area that were for profit. What happens is sometimes there's a difference between the non-for-profit and the for-profit in that the non-for-profit health systems generally, and I'm not saying it's always the case, are looking at the overall community benefit. There's definitely services within healthcare that reimburse less. And so in those areas, what we have seen in healthcare is that certain systems, when they see that the reimbursements are less and their costs are high, they start pulling out of those areas. And whether that's pediatrics or women's health, what happens then is that there's regions and counties where there's significant gaps in healthcare. And it has been the case in behavioral health too. There's significant gaps in behavioral health in many areas of the country, partially due to reimbursement. But as things become more costly, we expect that certain health systems are going to pull back more, and that's going to be to the detriment of patients and the communities.
Which is interesting. The three examples that you bring up, just historical examples, not anything operated on opinion or anything, but pediatrics, women's health, and mental health are all areas that are classically poorly reimbursed, right? We know that a pediatrician probably doesn't make as much as a cardiothoracic surgeon, even though their training is somewhat synonymous to some degree. I say that, not knowing exactly what their training entails. And so you look at, we value our kids. We all value the women in our lives, and we all should value our mental health in a way that's effective. But why are those considered second rate to a cardiologist visit, an endocrinologist visit, a hematologist visit, your primary care visit? It doesn't make sense. It doesn't make sense that those areas would be your first cuts based on the reimbursement being lower. And the problem is that the reimbursement, if it's not there, those are going to get sacrificed. You're exactly right. So they're going to go towards the only model that would make sense is that they have to have profitable service lines and they have to be able to eat up the cost in other areas. And so they'll take out things or unfortunately maybe not have the same resources available for those that don't pay the same.
Yeah, I think it comes back to a financial, aspect to it, right? Which you talked about earlier. Is although those models are large in volume, a lot of patients have mental health issues. Obviously, a lot of kids. Obviously, women's health, right? Common, statistically 50%. Let's just say the numbers there, right? Male, female. But the idea is, I think if you don't have it from an institution or anybody, even from a clinic standpoint, if you don't have enough volume to cover the costs of it, or there are more loss leaders in that space, then naturally out of any business or any for-profit, non-for-profit, however you need to do to keep the lights on, that's where the cuts end up happening. Mm-hmm. So we talked about this earlier. If there's any silver lining through COVID, if you want to say that at all, if you can say that, was that there was a big increase in access to mental health care. And I would even say pediatrics in rural areas and women's health care too, I would say. There was a lot of HRSA grants out for women's health care and stuff that we were reading about too during COVID. So a lot of these good things came out, but now we're shifting back into, I know Medicare's changing maybe this week we talked about, but there's a lot of shifts where that's going away. And we're going backwards almost into, okay, can you get telehealth? Can you not get telehealth? Do you get service? Do you not get service? Is your Medicaid active anymore? Or is it not active anymore? So it's like you went into increasing the population to get care, and now you're just drastically decreasing it. And it's not like, oh, hey, we're going to decrease it next year. These are the rules. These are really fine, tuned rules, and follow these instructions. It's, hey, this could change, and we'll let you know when, and if you got to find out if it happens. We don't even let you know in a fax or anything even.
It's pretty ambiguous, yeah. Yeah.
I was going to say at the same time, the reimbursements are going down, so the insurances are going down. the cost of things are going up. And so I think you guys run a business, and so the cost of hiring an APP, the cost of hiring an MA for your clinic, the cost of hiring just even a receptionist has gone up. At the same time, the cost of equipment, surgical masks are more expensive now than they were 5 years ago. And so all those things are, added together and make it even more tricky. So as reimbursements come down, the costs are still going up.
Absolutely. Outside of the Medicaid changes, or go ahead. Did you have another point you want to make? I apologize.
We're still, I would say we're naive to the business in the sense that we're newer, right? We're a newer company. Do the rates ever really increase? Is that even a thing to say? Do they really actually shift? Is it every 10 years they do restructure, you do typically see an increase? Because you hear historically all physicians talk about it, APPs talk about it, business owners talk about it, that over the course of the last 20 years, rates have been going lower and lower and lower and lower and lower. At some point, have we seen them ever plateau? Have they actually gone up in reverse?
It's interesting. So, government payers do go up, as do commercials rates go up. I think there's some argument that potentially the rate increase are not matching inflation. And so the increases there are, even if Medicare is paying, $2 more than what it was prior, that $2 more doesn't cover the increases of the cost of things. Right. I think that's why you're seeing such incredible consolidation in healthcare too. Because it's very tricky if you were a single community hospital to try to go to United Healthcare or Blue Cross Blue Shield or any other insurance payer and say hey, look, the way that you're paying us right now is no longer covering costs. Some of these big payers are just going to say, well, we negotiate on a large scale, and this is kind of the rate that we're going to give to you. But as health systems become bigger, then they have more negotiating power, which is probably why you're seeing a lot of consolidation in the industry today. Yeah.
We've seen it in mental health. We've seen a lot of privately owned clinics kind of combine together, work together. We've talked about it before in the past, actually, just saying, hey, how do we work with other clinics in the community just to do that as well? To increase Medicaid rates, to have more sustainability, to be able to handle these headwinds that come up with financial burdens that happen.
To try to create some leverage for ourselves.
Yeah.
To try to see if there's any opportunity to get a rate that would be more commensurate with the services we're offering, rather than just biting the bullet like we do often. In healthcare right now, so we talked at length about Medicaid and some of the changes that are coming, because that's obviously impactful with some of the changes that have come with recent acts and bills that have gone through. What are some of the other adjustments that we're seeing across healthcare, or things that we need to be prepared for in the near future?
I don't know if I would say H-1 visas, but I would say that's a topic that we've talked about briefly here too. But it's not I guess it is financially. I would say not financially, but it is financially. But the limitation or the more difficulty in getting H-1 visas, from a country that's run on immigrants, I would say, across the board, especially if you look at healthcare in general, right? There's a lot of immigrants in it, right? A lot of those are jokes half the time, but we as far as we joke around about it all the time. But I think that would be a big limitation. A lot of physicians are like that, a lot of training, a lot of research you were mentioning earlier too, which if you could shed some light on too, because we don't do clinical research yet, but it's been a conversation that we want to actually tackle, being that we're in pretty widespread and access to patients, peds, all these kind of disease states as well. And there's more funding in some CNS drugs that are coming out too, just like you mentioned, migraine treatments as well. But do you see that could there be a limitation on H-1 visas as far as its effect on research?
Yeah, I think so. I think there's a lot of talent out there that want to come to the United States. I think some of the recent changes in the way, whether it's research grants or visas are happening, the talent is not necessarily flowing into the United States as it used to. And I think in the United States, we pride ourselves a lot on having the latest and greatest innovation in the pharmaceutical world and in the research world. That potentially could shift for the negative. I have colleagues and friends that have gone down the academic route and research route, and they've seriously considered, does my work now with the cuts that have happened in research, does it make sense to maintain my professorship in the United States, or does it make sense to go to Canada? And so in those areas, where I think if this continues on for longer, we're at risk for losing significant research talent.
It's crazy.
Yeah.
Crazy to think about. I was talking to somebody, I think, earlier this weekend. When I was a kid growing up here, right, I think just from what I remember from school, which is very little, but the things that I do remember, right, where I always remember when we talk about America, we said it's like the melting pot. It was just the term that I just always remember from social studies before. And I almost feel like you need that immigrant power as well as local power as well to kind of continue to grow at the speed that the country's growing at. We're innovative as heck, obviously from a financial standpoint, right? It's like a stock exchange in general. International funding comes into this country. That's where you want to make your money. That's where the money's made. But if you lose that, if talent goes elsewhere, like we talked about Germany increasing it, Canada increasing H-1 visas to go there too, especially I have an Indian descent, so it's pretty easy to say Indians, then you have that risk of international funding now going into other countries as well. So then us here who have our retirement, 30, 40 years, or our kids were banking on their retirement to be through the market, right? Whatever you're going to do, 529, X, Y, and Z, that gets limited. So it's almost like short, narrow thinking that could happen now if we don't prepare for the future, I would say, if you limit that.
Yeah, it's loss of innovation. It's loss of opportunity. It's people with the skill set or the talent that Dr. Fu's alluding to going elsewhere or choosing another country, another industry, another setting to do what they need to do outside of what we're able to offer in the past. Or maybe there's a shift right now. Maybe that economic shift is hitting us in real time and we don't even see it yet, but we will in the near future.
Yeah. If you lose those obviously researchers, engineers that come over too, I think we talked about it earlier is, innovation in AI into healthcare right now. We're actively looking at, Sully AI, for instance, into integrating that into reception, into research, outreach for patients, scheduling as well, but also being a scribe for us, right? But they themselves are a group of engineers that are, a lot of them are H-1 visas that are here, whatever it may be, but they are, immigrant engineers that are developing this software. This is just one aspect of it, right? I'm sure there's hundreds out there, thousands if not, that are innovating healthcare as well. So we lose that innovation in our own specialties, in our healthcare.
Absolutely. And you lose the opportunity to work with a company like that if again, these current changes go through or these things are changed indefinitely. The opportunity there is AI in healthcare. And I think Sarang and I touched on it on a very, very mild scale a few episodes ago, and a few episodes ago, like a while ago. But we are seeing opportunities where AI, it can be viewed as a very scary thing. It can be used as a fear-mongering device, or there's a lot of usefulness, resourcefulness, and changes that it can bring about that can be very positive. And I like the fact that I think it's becoming, even just in the last 6 months, 12 months, 18 months, you're seeing more adaptation and more people within healthcare being willing to utilize AI or see what it can offer in AI. What are you seeing, Dr. Fu, and how has it helped either your practice or Bronson as a whole?
Yeah, I think one of the things that patients don't see is they see their physician or their APP that they're seeing, just within the room. And so the amount of time that the APP or the physician is talking to them in the room, they think that, hey, that's the amount of time I've gotten. But actually, there's almost an equal amount of time. So after a provider sees a patient, the provider then goes back and has to do all the documentation requirements, finish the note, update the problem list, do the patient advice instruction sheet. All those things take time. And so what we're seeing AI do is make those processes easier. We've actually done 2 large AI pilots at Bronson. And what we've been able to see is that those AI pilots not only improve the amount of time the providers are going back home and charting, but also improved ability to get better details within their notes. And so a lot of times you're asking the providers, the physicians, the APPs to go and recall what exactly they said to their patient. And if they're immediately able to get to the note, then they're able to call more. But especially if on a really busy day, they might not actually get to the note until the end of the day or in the evening time. And you're trying to remember things that you talked to the patient about, and then you're losing out on those details. But AI, if it's within the room, you're able to see that all those details come through in the patient note, and it's a much more robust note. We're starting also to take a look at how AI can help the providers in other day-to-day tasks. We know that kind of intersection between our health system and insurances are often problematic. And so thinking about prior auths or other areas where we are working with insurances to get something paid, those are often a lot of phone calls, a lot of phone tag, because I think the percentage of patients picking up their phones right on the first try have gone down with time. And so how can AI simplify those processes? Also, I think from the patient experience side, when you call a clinic, especially let's say they're calling Pure Psych, they're getting a receptionist that knows their clinic very well, but doesn't know the entirety of pure psych. And so can you use AI to help with scheduling that? So let's say a patient's calling one location of pure psych and they're being told, hey, look, we're booking probably 21 days out. I know you guys are focused on 7-day access, but what if there was another location 15 minutes away that could schedule them be seen in the next couple of days? And AI has some advantages there where it can kind of take all the information within the EMR, within your scheduling system, and be able to provide it to the patient on the spot. So I think there's some clear advantages in AI. And the interesting thing is there's such high demand and low supply in the healthcare system that there's a lot of areas that we could use optimization in.
Absolutely. And it still boils down to pass through and access. These types of things, there's no doubt about it. If you can have a tool or resource to be able to vet schedules and find opportunities for clients to be seen, get someone in sooner, you can prevent negative outcomes or prevent potential for ER visit or hospitalization or things like that. So when you look at cost cutting or just being efficient with your resources that are available, it's nice to think that we can find some way to optimize in the outpatient setting and maybe relieve some of the burden that are seen on the inpatient setting.
I do like that idea, though. I think that, and every time we talk, we actually learn more and more from each other. I think that having the receptionist do that, where it can ping someone from somewhere else if they can't get in fast enough. Because obviously, new patients within 7 days, but let's say you forget to make your appointment, something happens, the provider's on vacation, for instance, and we're like, hey, we'll get you in next week. The AI could then get them in faster with somebody else the same day, if not in the next hour, and then increase that. Which is kind of, we were talking earlier too, which is, we were really impressed and applaud you in that we haven't seen a healthcare system in our eyes move as fast as you move personally. I think that was really impressive for us as far as being innovative in AI, being open to talk about it, learning from each other as well, and coming up with a way that teams can work together that are privately owned, nonprofit, for-profit, X, Y, and Z. I think that was really, really awesome to see and learn from you as well throughout this whole process, which has been great.
Yeah, I think there's a clear advantage, and I know Pure Psych actually moves tremendously fast as well, but there's a clear advantage in healthcare for taking innovative, good ideas and being able to implement them. I've been a part of organizations that are slower at that, and so you kind of feel like you're talking about the same ideas for the 6 months.
Yeah.
But I think Bronson is really good at being able to take good ideas, implement them quickly, as similar to Pure Psych.
Yeah. To piggyback off of that also, we were talking earlier at our last conversation privately, we're trying to figure out a way to use AI, and this is just kind of a rambling thought here, but trying to use AI to say, okay, if we're not in a healthcare system per se, like we're not owned by a healthcare system or integrated in deeply in, but if a patient's seeing us and we know, okay, their primary care is at Bronson Health System, for instance, our AI should be able to know who your primary care is because we already put it in, or it can search for it, and then the AI should be able to automatically send a note to a portal if the PCP wants to be able to refer to it or not. And if not, at least be able to look at the most recent med changes. But don't make that where the prescriber or therapist internally has to send it out manually and do it and then receive it manually on your end. It should all be in the back end done automatically. So if I increase your Zoloft from 25 to 50 today, and I'll reschedule the patient, say, hey, I'll get you up front, they'll get you rescheduled, the patient should, one, get a text message automatically with the med changes so they remember. So at the pharmacy, they're not like, oh, what's going on here? Which happens all the time, right? But then two, the primary care should automatically get the note as long as an ROI is in the file to get that taken care of.
Yeah, it's a great idea. Increasing continuity of care, making sure that there's better communication between systems. And it's always been an age-old problem of EMRs not communicating. EMRs, the bigger EMRs do not communicate, and even the smaller ones don't communicate. But if there is a universal ability to share information with the appropriate ROIs on file, it would be game-changing for healthcare because you would get and have information in real time. If I, as a provider, got pinged for my client's, Lyrica being adjusted to 150 twice a day from once a day, and it impacting how I treated my client, it'd be wonderful. It would be wonderful to know that type of stuff or have it be logged in the EMR somewhere rather than having to ask or me go about asking, hey, has this been adjusted? Has this been changed? Has this been changed? And going down someone's laundry list of medications. It's not practical in a psych appointment. And for a primary care, even more so, when they're managing 15, 20 different medications and then trying to deal with mental health, if they had at the forefront, hey, I see your Zoloft was adjusted from 25 to 50. Are you doing okay? Are you still following up with Sarang? Okay, great. That's a part of their visit, but they know. It becomes an ability to just keep track of things and not lose track of what's important for your clients.
Even in ours, even in psych and neuro, right? I mean, just TCAs you mentioned earlier, Elavil, whatever you want to use for migraines, for instance. Sometimes you don't find out that they're on it until they tell you 6 months into treatment. You're like, okay, well, that's a high risk. We're on this and 2 other antidepressants and an antipsychotic as well. So I think that would help there as well. Hopefully then improving patient outcomes.
Because clients don't know. They don't know what class it is. They're not going to know unless we tell them or they're educated on it.
So when we say an improvement in patient outcomes, right? Because that's like obviously the end all goal is to obviously improve that. How is that, this is kind of dumb, but how is that scored? Or does it impact the reimbursement the hospital gets? Does it impact anything else besides saying, hey, like we have the best patient outcomes out of any clinic, out of any healthcare system? How is that tracked?
Yeah, that's a good question. So many different ways. So there's different metrics depending on the size of hospital, and there's different metrics for each service line. But there's things that we keep track of on a daily basis. Let's say readmission rate, mortality within the hospital, and we kind of compare that with how complicated the patients are. And so there's a kind of expected versus what the actual result is. We're looking at a 30-day readmission across different diagnoses. So patients that present with COPD versus CHF. And then access is also a big quality measure for us. So if a patient wants to see primary care, how soon can they get in versus orthopedics, for instance?
Right.
That makes sense.
It'd be important to check on our end too. I think privately owned, right? Because we talk about patient outcomes, but just as a general term. But versus a healthcare system, we don't really have a scoring system or track it manually. We were talking about saying we should track suicide rates and suicide attempt rates or ideation rates or post-hospitalization, how fast you can get in to the clinic. Would be huge things to track as well.
All good topics for us to look at, especially across this changing landscape in healthcare. I appreciate the topic, and I appreciate you both spending the time on this one. This was an interesting talk to go into some of the adjustments that we have to make, how we can be a little bit more proactive, and also unfortunately have to be reactive because we don't have clarity on some of these topics about some of the changes that are coming to our industry.